Good afternoon, and thank you for joining us for today's webinar, Seizing New Policy Opportunities to Help Low-Income Mothers with Depression, which will discuss our recently released brief with the same title. The webinar will also provide Medicaid and early childhood perspectives, as well as examples of local innovation. My name is Stephanie Schmidt, and I'm a Senior Policy Analyst for Childcare and Early Education at the Center for Law and Social Policy, or CLASP, and I will be moderating today's webinar. Before we begin, I would like to thank our generous funders who made the paper and our webinar today possible: the Alliance for Early Success, the Annie E. Casey Foundation, the Ford Foundation, the George Gunn Foundation, and the Irving Harris Foundation. We are happy to welcome participants on the webinar today from all the different sectors we are discussing, including Medicaid, mental health, childcare and early education, and many others, as well as participants from 41 states and the District of Columbia. Additionally, I'd like to quickly mention some housekeeping items regarding what you can expect over the duration of the webinar, which will be 1 hour. As you join the webinar, your phone lines were automatically muted and will remain muted for the duration of the webinar. We will save time at the end to take some questions from the audience. To submit questions throughout the presentations, please send them in via the chat box. You can also let us know about any technical issues you're experiencing through the chat box. This webinar is being recorded. The presentation and recording will be available after the webinar on our website, www.clasp.org. Next slide, please. Next slide, please. To begin, I'd like to start by introducing our distinguished panelists. First, you'll hear from Olivia Golden, who will provide an overview of maternal depression, the recent paper, and the policy opportunities identified. Olivia is the Executive Director of CLASP. She is an expert in child and family programs at the federal, state, and local levels. She has a track record of delivering results for low-income children and families in the nonprofit sector and at all levels of government. During the time that she served as Commissioner for Children, Youth, and Families, and then as Assistant Secretary for Children, Youth, and Families at the U.S. Department of Health and Human Services, Ms. Golden was a key player in expanding and improving Head Start and creating Early Head Start, implementing landmark welfare reform, and tripling the level of funding for child care and doubling adoptions from foster care. Olivia came to CLASP after working as an Institute Fellow at the Urban Institute, where she led major initiatives on poverty and the safety net, families' economic security, and children's well-being. Next, you'll hear from Donna Cohen Ross about the federal perspective and Medicaid as an opportunity. Donna is a principal at Health Management Associates, or HMA, in Washington, D.C., to which she brings over 30 years of experience in improving access to public benefits for families and individuals. At HMA, Donna is working with organizations focused on expanding and improving health coverage and on making stronger connections between health and other human services. Donna came to HMA from the U.S. Department of Health and Human Services, where she served as a Senior Policy Advisor and the Director of Enrollment Initiatives in the Center for Medicaid and CHIP Services, or CMCS. She created and directed the national Connecting Kids to Coverage campaign, which enlists national organizations and state and local partners across the country in efforts to identify and enroll eligible children and parents in Medicaid and CHIP. During her tenure, Donna designed and implemented policies to facilitate enrollment in Medicaid and CHIP using data from other public benefits programs, such as the Supplemental Nutrition Assistance Program, or SNAP, which resulted in hundreds of thousands of newly eligible individuals gaining health coverage. At CMCS, Donna also worked with the prevention and quality teams. She drafted guidance released in May 2016, which you'll hear about shortly from her, clarifying Medicaid's role in maternal depression screening and treatment. Then you'll hear from Dr. Megan Smith, who will give us a clear example of local innovation. Dr. Smith is an assistant professor of psychiatry and child study and lecturer in the School of Public Health at the Yale University School of Medicine. Dr. Smith's research and teaching interests are in the intersection of maternal and child health and mental health in low-income families. Specifically, she conducts clinical research on the prevention of mental illness in women and children with a specific focus on maternal depression and trauma. Dr. Smith has worked for the past 10 years in the area of perinatal depression, serving as an investigator, evaluator, and project director on several federal, local, and state grants and initiatives. Dr. Smith is currently the lead evaluator on the Connecticut Health Foundation's statewide Children's Mental Health Initiative and principal investigator on a U.S. Department of Health and Human Services Office of Women's Health grant for the New Haven Mental Health Outreach for Mothers, or MOMS Partnership, a community academic collaboration to create public mental health programs for low-income mothers in New Haven, Connecticut. Dr. Smith serves on the Connecticut Maternal and Child Health Advisory Committee and is a current recipient of a Building Interdisciplinary Careers in Women's Health Career Award from the National Institute of Health, Office of Research on Women's Health, and a Young Investigator Award from the National Alliance for Research on Schizophrenia and Depression. And finally, you'll hear again from me about the early childhood perspective. Following the presentations, we'll have time for question and answers from the participants. As a reminder, please enter your questions in the chat box and we'll get to them at the end of the presentation. And now, without further ado, I'll turn it over to Olivia Golden to begin.
Thank you so much, Stephanie. It's wonderful to be here with great panelists and an amazing audience. As Stephanie said, we have representatives from each one of the fields we were hoping to bring together and 42 states, so that's really terrific. Next slide, please. What I'm hoping to cover today in the overview is 4 things: why maternal depression matters, why we embarked on this particular brief, which is a policy scan of states, what we found, and then action, how to seize the moment. Next slide, please. I want to start talking about why maternal depression matters so much with the one big theme that I know everybody on the call who works on early childhood and child care issues knows, which is that probably the single most powerful finding in child development research is the role of parents in children's development. That's true because parenting, having a nurturing and stimulating caregiver relationship is central to children's learning, their emotional development, cognitive development, and for very young children particularly, because parents are so central, also to their health and safety. Next slide, please. So in that context, let's take a look at why maternal depression matters so much. I think the summary is that it gets in the way of a parent being the parent that she wants to be and that her child needs her to be. The particular information, which is summarized in much more detail in the brief, maternal depression is frequent. It's got a high incidence for all mothers, but particularly for low-income mothers. And the big issue for low-income mothers is that while depression is highly treatable, many low-income mothers, far more than middle-income mothers, don't receive treatment. In 2009, the Institute of Medicine did a long report synthesizing all the research about depression. And they basically said it's the most treatable of mental health conditions. We have lots of good evidence, but for a set of reasons, of which financial access is front and center, although not the only one, many low-income mothers don't get any treatment. And untreated maternal depression holds back young children's development and hinders mother success at school and at work. So the Institute of Medicine report concluded that untreated maternal depression is a big public health risk, but the flip side of that is that there's a big public health opportunity, since we know how to treat it, if in fact we successfully identify and treat maternal depression. Next slide, please. So that brings us to the report we're talking about today. It's the context. CLASP has been doing a series of work and papers on maternal depression. This specific paper looks at state policy opportunities, and it's by Stephanie Schmidt, who you've met already, and Christina Walker, who's a policy analyst here at CLASP. Next slide, please. So let me start by saying why it is that we decided that a scan of state policies was the right next step at this moment. Next slide. The headline about why we embarked on this particular report is that the Affordable Care Act, Obamacare, health reform, has made a huge difference in the policy levers that are available at the state level particularly to make a difference in identifying and treating mother's depression. But we really didn't know how ready states were to take advantage of that opportunity, and so that's what we wanted to find out. And just a very quick summary for those of you who may not do this every day about the ways in which the Affordable Care Act changed the policy landscape. First is Medicaid expansion. You'll hear more about that from Donna. 31 states have taken advantage of the Medicaid expansion option. And what that means is that all adults, and in particular for this purpose, all mothers, are able to get health insurance under Medicaid, or if they have more income, under the exchange, but under Medicaid up to a bit above the poverty level. But the Affordable Care Act offers other opportunities as well. It strengthened mental health benefits, obviously important for this topic, strengthened coverage of preventive services, and provided opportunities for bringing together primary care, your family doctor, and mental health. In addition, so that was a big policy context that set us on this work. But while we were writing the paper, the federal government took 3 additional actions that made the policy levers even clearer and more evident for states. One was a step taken by the U.S. Preventive Services Commission, which has as its mission to look at the research and figure out which preventive activities, screening tests, other kinds of preventive steps, pay off in terms of the best available research. And they came to the conclusion that screening for depression for all adults, including postpartum women, was a high priority preventive services step. And as you'll hear from Donna, that has financial implications for states and insurers, so it's a really helpful hook to get people to pay attention to depression. The other 2 federal actions are guidance by the agency that oversees Medicaid that help states be clearer about what policy steps they could take to support home visiting through Medicaid and to support screening and certain kinds of treatment for mothers with children. And that's, again, a topic that Donna will tell you more about. So our question was, here we have this big federal policy climate, and here we have opportunities for states to take action, but what can we learn about the extent to which they really are taking action? And in particular, what do we know about who's involved in that? Is the early childhood world, which obviously has a stake in young children's well-being, the health world, the anti-poverty world, the mental health world, are they able to work together to seize these opportunities? Next slide, please. Just very briefly, we looked in detail for the paper at 4 states that are quite different from each other. And the only thing I want to highlight now, we can talk about your questions later, is that 3 of those 4 states had taken the Medicaid expansion, meaning they were able to reach all mothers, including all poor mothers. Virginia has not, at least as of now, and so there are a substantial number of mothers in Virginia who are very poor, yet are unable to get support for access to health care. Next slide. So what did we find when we went in and did those interviews? Next slide. One of the 2 headlines was that there was actually a lot going on. The second headline, which I'll come to in a moment, is that there were also a lot of barriers. But we were very happy to see the positive headline because we were worried that if all we saw was frustration and difficulty because this is all too complicated, we wouldn't have a lot to say yet about how to go about seizing these moments. But we actually did find a lot going on. In every one of the 4 states, there was at least one of the people we interviewed who could point us to an existing local or state innovation for identifying and treating maternal depression. And while some of these are small now, they often had the potential for large-scale change in the future. So, for example, there might be something happening at the local level that pointed up a policy change you could make in Medicaid that would make it easier for innovators all over the state to do the same thing. And in addition, stakeholders everywhere had lots of ideas about what should be better in the future. Next slide, please. So I'm only going to talk about a couple of these. There are many examples of innovations in the paper. So when you read it, you'll see many more than these four. I'm going to say a little more about two of these. You'll hear more about the Connecticut Moms Project in a moment from Megan, and you should ask lots of questions. So the first of these innovations started in Ohio. A number of clinicians in Ohio, including Dr. Robert Ammerman, came up with a new approach to providing maternal depression treatment, which was designed to pair with home visiting. So when a mother's reached by a home visitor who screens, who identifies maternal depression, this is an approach to treatment where there are trained mental health clinicians who have a specific treatment approach and protocol and who can go out to the home, be introduced by the home visitor, build on that relationship to provide treatment, and it's one of many maternal depression treatments that have been validated by rigorous research. So at the beginning, it was supported as kind of a special project. But the important insight that's relevant to expansion here is that what we learned in our interviews is that it's now in 10 states, and in 4 of those states, this is after all a mental health treatment. Medicaid covers mental health treatments that are validated. So Medicaid is paying for the treatment. And that was a very important insight that could be relevant to other states. The second example in Virginia, which you'll recall I told you was not an expansion state, and so a large number of poor mothers just don't have the financial access to treatment. So advocates there, when we talk to them, were exploring dyadic treatment, which means treatment that would help a mother and baby together. That's not likely to be everything a mother needs, but it is likely to address some of the implications of her depression. And they were exploring that because poor children are covered by Medicaid, and so they would be able to reach everyone. Well, lo and behold, in the course of our interviewing as we were writing the paper, the federal government came up with new guidance saying that states could, in fact, use this strategy to cover these kinds of treatments based on a child's eligibility. And Donna will tell you more about that. So let me move on to the next slide, please. All of our stakeholders had a lot to say about future innovations that they would recommend in their states because nobody thought everything had gotten to where it should be. And I'm going to tell you about those in the context of the barriers because they typically told us about those at the same time. So let's move to the next slide, which highlights the barriers. So the two big themes, I said one was that there is lots of emerging innovation to seize the promise of the Affordable Care Act, but the other is that there are substantial barriers which everybody told us about. So one big one is fragmentation, and I suspect that many of you on the call feel as though it would be overwhelming if you do early childhood to try to understand Medicaid. If you do Medicaid, you've been implementing the Affordable Care Act, it would be overwhelming to try to reach out to additional people who are going to give you new ideas of things to do. Bandwidth in the child care and early education world where people are dealing with many things with very few staff was also on the list. But people did have a lot of solution ideas. They had a lot of ideas about how to design collaborations, how to build bigger policy collaborations out of either existing meetings or existing service level collaborations. That they had ideas about incentives that would help bring people to the table. So there are lots of potential solutions that people are thinking about for these barriers. Then you'll see that the third bullet there is about barriers that come out of Medicaid policies. And I highlighted before all the opportunities in Medicaid policy, but it's extraordinarily complicated, different in every state, and policies were created generally for totally different reasons that are not about maternal depression or these families. So there may be reimbursement barriers, there may be rules about qualifications of providers and who can do what that may not make sense in this context. There can be just all kinds of obstacles. And so the paper offers a detailed list of some of the policies that we think would be high priority for states to look at as they're trying to work to make their policies more supportive of this agenda. In general, that's about state choices, not federal choices, though I think, as Donna will show you, having the federal government be able to explain things clearly helps states feel comfortable and helps them not have to reinvent the wheel. Lack of Medicaid expansion, of course, is a major barrier. We have a paper actually coming out tomorrow, I think, that Stephanie has co-authored with a colleague at the Georgetown Center for Children and Families, which highlights the importance of this issue, maternal depression, as a reason for Medicaid expansion. And finally, there are, of course, other barriers beyond financial access for mothers: lack of qualified providers, childcare, transportation, not trusting the quality of providers or worrying about stigma, and all of those people had strategies for addressing. Next slide, please. Okay, so now I want to turn in closing, in my last minute, to what we say in the paper about action steps. Next slide. We offer action steps for state decision makers and advocates and for philanthropy in the federal government. And I'm hoping maybe we'll come back to all of these in questions. So there's lots more in the paper, but essentially our recommendations for states boil down to two big ones. The first is, this is a moment when you can take advantage of these federal actions that raise the visibility and give new incentives for states to address this issue, to reach out to us and other national and peer experts. The last slide in this presentation gives resources and contact information to us. And it's a great opportunity to convene stakeholders to kick off this work. And we would be delighted, as I know many of our colleagues would, to try to work with you to seize this opportunity. And the second thing is that we think one of the big goals of these convenings should be identifying and implementing policy improvements in Medicaid. Because if you fix the way your Medicaid system funds and supports local programs, you open the door to major improvements at scale. Next slide. Okay, so I'm not going to dwell on this, but just to note that we think philanthropy has a really important role in supporting this work as states figure out how to proceed and as we at the national level help that. And the federal government, both in this administration and we hope as a big transition priority for a new administration, can really help states not reinvent the wheel by providing high quality joint guidance and technical assistance. So I look forward to your exciting ideas about action and to your questions, but now let me turn this over to Donna Cohen Ross.
Great. Thank you so much, Olivia, and thanks to CLASP for conducting this webinar on this very important topic and for inviting me to participate. I'm really delighted to be here. I'm going to start by describing the federal guidance that Olivia mentioned, and then I'll talk a little bit about what state Medicaid agencies are doing and what they can do. And why don't we go to the next slide and I'll begin. Actually, the next slide and I'll begin. Great, thank you. So the new guidance that Olivia has referenced is called Maternal Depression Screening and Treatment, a Critical Role for Medicaid in the Care of Mothers and Children. Now this guidance was released from the Center for Medicaid and CHIP Services, that's CMCS, as an informational bulletin. So you'll see in the slides I refer to it as the SIB, stands for Informational Bulletin, that's all, and it was released on May 11th, 2016. This is the link to that guidance, and I think there'll be some resources at the end as well. A big thing to keep in mind as you read the guidance and as we talk, that really we're talking about the role of pediatricians and pediatric care providers in helping to address this problem, and this is a really critical piece. Earlier, Olivia mentioned some barriers that mothers may face in getting screened and getting treatment, and there are financial barriers which we'll talk about, but there are also other barriers like stigma around seeking care for mental health problems, for emotional health issues. And one of the things that's really important is that when you're thinking about what happens in the pediatrician's office, or the idea of parents and caregivers taking their children to the pediatrician's office, not only is there virtually, I don't even know virtually, but no stigma related to that. It's quite the opposite. It's something that is expected of parents, and so there's really no barrier in terms of a desire to take a child to the doctor, pretty much. And so trying to address this issue through the pediatrician's office is a really important opportunity. And then when you think about the access that pediatricians have with very young children, they probably have the most routine access of any type of provider. Generally, they see children about 13 times in the first few years of life, and so they do have an opportunity to have a very special relationship, not just with the child, but with the caregiver, with the mother as well. So keep these items in mind as we talk, and we're going to go to the next slide. So what does the informational bulletin say about screening? It says very clearly that state Medicaid agencies may cover maternal depression screening as part of a well child visit. So again, when the pediatrician is working, is examining, is seeing the child in a well child visit, maternal depression screening is something that that pediatrician may do, and Medicaid will cover it. State Medicaid agencies can allow those screenings to be claimed as a service for the child as part of the EPSDT benefit. And for those of you unfamiliar with that alphabet soup, EPSDT stands for Early and Periodic Screening, Diagnostic, and Treatment Benefit. That is the package of benefits for children in the Medicaid program. As its name implies, it covers screening when issues arise as a result of those screenings. It covers further diagnosis and also treatment. So it's a very rich, comprehensive benefit for children. And basically what this is saying is that providers may bill the child's Medicaid for screening that is conducted with the parent, with the mother in this case, not always the mother, but generally the mother. And so why is this really important, and why has this been in some places called a breakthrough? And that's because the mother is not the pediatrician's patient, the child is. So the idea that a pediatrician screens a mom for depression, and we'll see it's something that's recommended in pediatric practice as a best practice, but it gets tricky because the mother is not actually the patient. And so having access to the mother's health records, again, billing issues become very challenging. And so the idea that in fact we can think about maternal depression screening as a service in the best interest of the child, a service for the child, makes this a much smoother pathway for the pediatrician to deliver the service and also bill for it. Let's go to the next slide, please. So what does the informational bulletin say about treatment? The informational bulletin reminds states that states must cover any medically necessary treatment for the child as part of the EPSDT benefit. That's true across the board. And that diagnostic and treatment services must actively involve the child, relate directly to the needs of the child, and in this case, be delivered to the child and mother together. That's that dyadic treatment that Olivia mentioned earlier. Again, the key piece is that the treatment is directly related to the needs of the child. That's the reason that you can think about EPSDT as the vehicle for delivering this care, but again, delivered to the child and mother together, dyadic treatment. And again, these services can be claimed as a direct service for the child, and again, that means providers may bill the child's Medicaid. Now, services that are directed solely at the mother would be covered under Medicaid if the mother is Medicaid eligible. As Olivia also mentioned earlier, the dyadic treatment can really be very, very important and take the mother and child dyad a long way, but there may certainly be situations where mom needs even more care. She might need medication, she might need therapy on her own. Those would not be considered dyadic treatment, and so for Medicaid to cover those activities, the mom needs to be enrolled in Medicaid as well. Let's go to the next slide. Okay, so as Olivia mentioned as well, there is a great new opportunity in many states, 32 states, including the District of Columbia, which have expanded Medicaid. In these states, more adults are eligible for Medicaid than ever before, and of course this includes parents, this includes mothers. And so there is more opportunity than ever that if depression is identified, that there's an opportunity for mothers to get the full range of care that they need, certainly starting with that dyadic care, but going further if it's necessary. And this map tells you, as of today, which states are expanding Medicaid and which have not yet expanded. Let's go to the next slide, please. So what about mothers who aren't Medicaid eligible? What about mothers who are in states that haven't yet expanded Medicaid or for other reasons may not be eligible for Medicaid? Well, those mothers can benefit from dyadic treatment that's aimed at reducing the effect of the mother's condition, the mother's depression on the child. So again, that dyadic treatment is really important. Again, thinking about this treatment as a preventive service for the child, right? Reducing the effects of the mother's condition on the child. Providers can refer mothers who may need more care to community mental health programs, federally qualified health centers, or home visiting programs that may go further in this area. And again, as Olivia noted, there's another informational bulletin that was released from CMS just a couple of months before the Maternal Depression Screening and Treatment Bulletin. The data's here for you, March 2nd, 2016, that talked about home visiting services and which of those services that are generally conducted by home visiting programs, which are Medicaid coverable. So that's another resource for all of you to look at when you're thinking about the avenues for providing screening and treatment for mothers who may be suffering from depression. But again, the point here is that for mothers who are not Medicaid eligible, they can still participate in that dyadic treatment with the child. So that's very, very important. And then for further help, there may need to be referrals made to these kinds of programs or others that may exist in the community. Let's go to the next slide. So now I just want to, without being repetitive, I wanted to take a step back now and talk about why this is so important and what prompted CMS to look at this issue and try to clarify policy in this area. And I won't take a long time on this because Olivia gave you some of the data, which is simply repeated here, but the main point being that maternal depression has such detrimental and lasting effects it affects mothers, but it also has that lasting and detrimental impact on the child's health, affecting child development, potentially affecting other health issues for the child. And so identifying maternal depression early, getting that treatment to mother and child together as early as possible are critically important for child development and all that we want to happen for children going forward. Let's continue. Again, this talks about some of the research that looks at the effects, the impacts of maternal depression, and so we have studies that talk about children performing lower on cognitive, emotional, behavioral assessments than children of non-depressed mothers, looking at risk factors later on for the child with respect to mental health problems, social adjustment, school difficulties. And this was one piece that was in the American Academy of Pediatrics practice statement on this topic, and I think this is really important. If maternal depression persists untreated and there's not intervention for the mother and that dyadic relationship, the developmental issues for the infant also persist and are much more likely to be less responsive to intervention over time. So this is the, I think, the call to action to intervene as early as possible so that you have the best chance of positive effect going forward. Next slide, please. Again, Olivia mentioned, we've talked about American Academy of Pediatrics, the guidelines for health and health supervision of infant, children, and adolescents, the Bright Futures, talks about maternal depression screening. There are other practice statements from AAP that talk about the importance of maternal depression screening and dyadic treatment. Those are all, by the way, cited in the federal guidance, and Olivia's also talked about the U.S. Preventive Services Task Force. I will just mention that the advantages that she mentioned for states is that if a state covers all of the preventive services that the task force gives an A or B rating, and those ratings are based on the research that supports the importance of any given practice. It looks at the evidence. It looks at the benefit versus harm of providing those services. So any of the treatments that the services that get an A or B rating, along with some immunization guidance for states that take on all of those, they can be eligible for a 1% bump in reimbursement from Medicaid. So it's an incentive for states to cover that whole collection, that whole constellation of service. Again, those services are provided free in the Medicaid program, and the incentive is that bump in what we call the FMAP, which is the reimbursement. So far, my understanding is there are 11 states that fall into this category of covering all of these preventive services, but that's something to look at in your state. Let's move on. So I wanted to just mention, and these states are mentioned in the bulletin. There are other states as well that are already conducting screenings and treatment, but I just wanted to give you a flavor of some of the states that are already doing this. Again, Medicaid paying for the treatment, providers being allowed to bill on the child's Medicaid. And you can see states still have a lot of discretion and a lot of flexibility in how they pay for screening and under what conditions, but this gives you a sense of the kinds of approaches that states have taken in these 4 states. And again, some of them are more prescriptive than others, talking about particular standardized screening tools that need to be used. Some of them talk about how many times a mom can be screened over a period of time. Again, states have a fair amount of discretion here. Let's move forward. North Carolina is an example of a state that covers, under Medicaid, covers the dyadic treatment, and you can see there are things to know about the number of visits that can be covered and what types of providers can deliver the dyadic treatment. Next slide, please. The informational bulletin also talks about promoting maternal depression screening under Medicaid. It talks about the kinds of things that states can do to promote the screening, to encourage and assist providers in moving forward. So you can see, simple things like posting information on provider websites, publishing in provider newsletters. In other words, letting providers know that this is a practice that is coverable under Medicaid in the state. There might be need for training on how to use screening tools and proper billing codes. In some states, in-person visits to clinics have helped in training
pediatricians on how to implement the screening, showing them how to modify clinic flow so that they can add this new activity into what they're already doing, discussion of referral strategies, some other things as well. What the informational bulletin does say is that some of these activities are allowable administrative costs and are also reimbursable at the usual 50-50 reimbursement rate, 50% federal and state match for administrative costs. So this is really important for a state that isn't doing this yet. There might be some startup issues that might seem a little daunting, but there's support for helping to move those forward. You can move to the next slide, please. So I think finally, in just some thoughts about making this happen. I know we have a lot of people from different disciplines on the webinar today, so hopefully the wheels are starting to turn in your heads about what you might be able to do. If you're not a state Medicaid agency, I hope that you'll consider the informational bulletin an advocacy tool, something to use with state Medicaid agencies, Medicaid managed care plans, other state and local allies to explain the importance of maternal depression screening and dyadic treatment and what is possible because of the new informational bulletin, but also the opportunities under Medicaid, particularly in states that have expanded Medicaid to more adults. This advocacy tool can really help in being that conversation starter about what is possible. States don't need a state plan amendment to begin this practice. They just need to notify providers of the opportunity to screen and bill. And again, each state may have some different specifics about what it wants providers to know. And again, as I mentioned earlier, the promotion and training associated with getting these activities underway are generally eligible for Medicaid administrative matching funds. And that's going to be really important for that startup period. And then, as the bulletin mentions, states that want managed care delivery systems to think about this, to pick this up, they need to assure that services are appropriately reflected in their Medicaid managed care plan contract. So there's some other things that a state would do if they envision this happening through managed care, which is increasingly, a common way to go about this. So I think that's where we land.
Great, thank you, Donna.
Right. I'm passing this back to Stephanie. Thank you.
Thanks, Donna. We appreciate it. And we were hoping to save a little time now for questions for Donna as she has to excuse herself a little bit before the question and answer period. But due to time constraints, we're going to move right into Megan Smith's presentation. So Megan, take it away.
Wonderful. Thank you so much, Stephanie. Really a pleasure to be here to talk about such an impactful brief that CLASP did in the report. And Donna really nicely outlined the concrete federal examples of guidance and state examples as well. So I want to give it now a local example of what we're doing on a citywide level to address maternal depression in partnership with mothers, in partnership with community providers, and also in partnership with our state of Connecticut Department of Social Services. And really, if you could go to the next slide, please, that would be wonderful. Really thinking about three key features of the MOMS partnership, and one is thinking about innovation and the delivery of mental health services for mothers. So who's delivering the services, where they're delivered, and how they're delivered. Also, as this slide illustrates, really the critical need to partner across agencies that was mentioned already. But as we can see, all of these different sectors are impacted by the effects of maternal depression, both for mothers, children, and the larger family system. And so that these systems are often disproportionately burdened by maternal depression, and thus, the importance of coming together as a coherent system and partnership. And finally, as I mentioned, really what the MOMS partnership does is partnering with mothers themselves. So Olivia mentioned, stigma with mothers seeking services, and really there are particular stigmas for mothers who seek mental health services related to maternal depression. For example, a mother's fear that her children might be removed if she should seek mental health services, and that is a very real an issue that must be addressed as well. If we can go to the next slide, please. So one of the first steps we undertook in the Moms Partnership was actually to think about formally partnering with agencies that are impacted by maternal depression through formalized memorandums of understanding and agreement. And after we partnered with several agencies here that serve families, we really came together around the issue of screening. And what we did at that time in our state and our system here was we were screening mothers for depression across 2 federally qualified health centers and 2 hospitals. And this slide is showing you data from one of our studies we did on this early screening initiative. And really what we found was we screened mothers when they were pregnant, when they were newly postpartum, and we referred mothers to treatment. And these are low-income mothers, primarily mothers who are 200% below the federal poverty level. And we screened mothers, and mothers who were probably depressed were referred to treatment. And then we followed mothers for about 6 months to understand if a mother engaged in mental health treatment. We had a fairly low bar for engagement in treatment, which was 1 visit. And we know, of course, that wouldn't be adequate care, but we wanted to just measure engagement. As you can see from the slide, only 30% of mothers actually engaged in mental health care. And that's one story, but the other story about this slide is to tell you the mental health care we offered free care, we offered child care, transportation, we offered care in English and Spanish, and eventually we started actually paying mothers to come to care. And even with all of these ancillary supports, we still were only able to engage about 30% of mothers in treatment. And so it really became important to us as a collaborative across the systems I showed on the prior slide to think about how we could better create a system of care for mothers with depression from screening through, through treatment, that dyadic treatment that Donna talked about. If we could go to the next slide, please. And really our finding, as was mentioned, is really not that dissimilar from what we know nationally. So, we know, of course, that women are much more likely to be diagnosed with depression than men. But when we think about that intersect of low-income women, and in particular, actually, racial and ethnic minority women, there's really an intersect that suggests there's a high proportion of unmet need in this population to address maternal depression. And so it really emphasizes the importance of a brief report like the one CLASP did here, and it really emphasizes the importance of thinking differently within Medicaid systems about how we can reduce some of these disproportionalities and inequities, perhaps, in the treatment of maternal depression across different subpopulations. And so not only is it an issue about engagement in care, but it's really an issue about the quality of care that's received as well once families are engaged in care. So again, initiatives that support and provide reimbursement for dyadic treatment are so critical. And so in the Moms Partnership, we were really formed again around this idea of what we could do to increase engagement, particularly for low-income racial and ethnic minority women. And one of the pieces we put in place was to borrow extensively from the global literature on maternal mental health and something called task shifting. And if we could go to the next slide, please. And task shifting is training non-professionals to assist with the delivery of mental health care, assist clinicians with the delivery of mental health care. So it's somewhat akin to a community health worker model. And what we did in the Moms Partnership, once we had formalized our partnerships with different agencies and organizations, was to actually work with mothers from our community that we termed community mental health ambassadors to collect data from other mothers around maternal depression, around who and what supports them as mothers and their goals. And what we found from over 3,000 women was that, a number one goal of mothers was not surprisingly to be a good mother. The other goal was to secure a job or get a better job. And they really talked about the supports from subsidies like food stamps and rental assistance being critical to their goals of parenting and securing employment. If we can go to the next slide, what for many mothers, and again, this is systematic data around maternal depression, but what mothers talked about getting in the way of their goals was what was broadly defined as stress, but when we talked to mothers was depression, and really depression and trauma, and particularly social isolation. And mothers talked a lot about, their fear, as I mentioned, of seeking services due to stigma or fear of being judged as a mother, or also fear that they wouldn't gain employment if they disclosed that they were struggling with depression. You can go to the next slide, please. And what we did with all of our data once we collected it, and this is an example of, you'll see here, the city of New Haven, is we mapped our data to really understand where the highest needs were in neighborhoods on maternal depression. We mapped services that were available. But one thing that came out of our data that we've now integrated into how we deliver our program is really when we think about operationalizing poverty and how it intersects with maternal mental health, there's something around diaper need. And so we heard from so many mothers when they couldn't afford a supply of diapers, an adequate supply of diapers, how this really impacted their own stress levels. And so we have actually incorporated diapers into our program of mental health service delivery here as an incentive for mothers to receive services. And currently working with our state in the Department of Social Services here in Connecticut to think about how we can incorporate diaper subsidies into potentially Medicaid or other programs for parents to use to incentivize services. If we can go to the next slide. And really to take you to where we ended up after we talked to 3,000 mothers, again, about maternal depression, is we ended up with this model of the Moms Partnership. We used what we heard from mothers around their goals and what got in the way of their goals to create this citywide approach to maternal depression. That's a bundled approach. And the bundled approach, again, includes all of those partnerships with agencies I talked about. It includes taking one of the most efficacious treatments for depression, psychotherapies for depression, cognitive behavioral therapy, and locating that in community settings we call hubs. So it's another version of co-location, but taking mental health care to the community. In many ways that enables us to reduce the stigma associated with mental health care. So we're conducting the screenings we heard about, we're providing services in community settings. We use community mental health ambassadors, that model that's similar to community health workers, who are mothers from our New Haven community who are trained in brief mental health outreach and delivery of cognitive behavioral therapy with clinicians in a group setting. We also have a very robust workforce training component that focuses on addressing depression for mothers and then putting mothers on a pathway to work and employment. And all of this is really done in a group setting to promote social networks and support. And not surprisingly, when you take a highly efficacious intervention for depression for mothers and you put it into community settings with high fidelity, we see a decrease in depressive symptoms. We see an increase in parental functioning overall for mothers. And also really interesting is we've seen a dramatic increase in utilization and adherence to mental health services. And I should note here that a lot of this is being done in partnership, as I mentioned, with the state to think about what we're doing now is collecting very systematic data on the use of community mental health ambassadors. So can we, and part of that data is around cost effectiveness. So if we're able to show the cost effectiveness of community mental health ambassadors, thinking about the possibility of applying for an 1115 waiver to cover the services of community mental health ambassadors. But right now these services are in the process of actually being billed for through Medicaid. And if we can go to the next slide, I'll just conclude by showing you a few of the pictures. So we're providing mental health services for mothers, again, that we're billing for in supermarket settings. So here's an example of where we provide services in our Stop and Shop, our local supermarket. And if you go to the next slide, just an example of pictures. So the top right is a boys and girls club. So you see the foosball tables and there's a basketball court and we have a room there where we provide services. And then the bottom left is in conjunction with our public school system at a building right next to one of our public schools here in New Haven. And then finally, if you just go to the next slide, there's our website if you want further information. I'm conscious that we're running low on time here. So our website is there for any additional information. And I'll turn this back over to Stephanie.
Thanks so much, Megan. Now I'm going to talk briefly about the early childhood perspective and the role for early childhood providers and stakeholders in meeting the needs of parents with maternal depression. Next slide, please. Of course, we know that many children are in childcare and early education and have parents whose mental health is important to address. And that's because we understand that the two generations impact one another. So at CLASP, we take a two-generational approach to policy, which takes into account the needs of both the parents and the children. Parents are clearly extremely important to a child during their earliest years, as this is a time where they're predominantly dependent on their parents to meet all their needs, making the parents' mental health so important, as Olivia mentioned earlier in the presentation. Let's go ahead and skip the next two slides in the interest of time and go to the slide about why childcare and early education. Just to talk briefly about why childcare and early education is so important to meeting the needs of families whose mother might be suffering from maternal depression, we can think about early childhood as an important component of this. We know that Medicaid health and mental health experts really stand to gain in a number of ways by including childcare, early education, and family services representatives in the design of maternal depression policies. Childcare and early education experts and practitioners who are often interacting with families on a daily basis already know a great deal about the circumstances of low-income children and families, potentially serving as a crucial source of insights, information, and questions to be addressed through data collection. Childcare and early education practitioners may also have a frontline view of the limits of the state's current policies, and they may be able to tell stories and otherwise contribute in communicating to the public and policymakers about the importance of addressing the mental health needs of both children and their parents, and the potential negative effects of untreated maternal depression on young children's development and education. In addition, depending on the state and the specific goals of the initiative, childcare and early education practitioners can potentially support policy goals by playing a role in delivering services using a variety of funding streams, including Medicaid reimbursement, for example, through outreach to mothers or case management services that build on existing relationships. Early childhood providers may be especially successful at engaging mothers, particularly when they provide information to them about the implications for their children. There are also important reasons for childcare and early education providers and stakeholders to collaborate with Medicaid and mental health stakeholders in driving change, even if the Medicaid system initially seems too complex. Most crucially, by working on a system-wide redesign, childcare and early education stakeholders have the opportunity to dismantle barriers they currently face in trying to get mental health treatment for mothers, eventually reducing workload and making the system more responsive to local programs as well as to families. In addition, if a redesigned system genuinely works for mothers, it will lead to real improvements in young child's well-being and behavior in early education programs. As the childcare and early education sector knows well, mental health concerns in a young child will manifest in disruptive and problematic behaviors by the child while in care, and these mental health concerns can usually be linked back to difficult aspects of the child's life at home. A successful redesign that truly improved access to treatment could also help childcare and early education providers who themselves experience depression. Very often, as low-income working mothers themselves, childcare and early education staff are also at risk for experiencing untreated depression. One study found that 7 in 10 of the early childhood teaching staff worried about paying for routine healthcare costs for both themselves and their family members. Depending on a state's specific circumstances in the design of its initiative, childcare and early education stakeholders could also identify funding through Medicaid for certain aspects of what they do now or would like to do. For example, the guidance that Olivia and Donna both referenced, CMS identified that Medicaid funding authorities could reimburse for home visiting activities conducted by those who are not physicians or for preventative services recommended by a licensed professional but furnished by non-licensed professionals. We'll go to the next slide. And now we have just a very few minutes left for a few questions. So I'll ask one question of Olivia and one question of Megan. And as a reminder, please submit your questions through the chat box. If we are unable to get to them in the next few minutes, we'll be sure to follow up via email in the coming days. So let's start with the question for Olivia. Olivia, one of the participants asked, how can we go upstream to deal with maternal depression that is caused by trauma associated with poverty, institutional racism, and inequality? Olivia, you may be on mute.
Thank you. So I think that's a great question. How do you think about the role of poverty, institutional racism, and trauma? To me, it's a both and, because a mother who's experiencing depression today is her ability, as you heard in the interviews and data that Megan summarized, she's having trouble going to work. She's often, I mean, if it's severe depression, she's not able to get up in the morning to deal with her 6-year-old baby and her baby's needs. Once she's depressed, it's getting in the way of everything she would do to meet her needs. So to me, one strand of what you do is address that. She should have access to the same treatment that a colleague who I was just talking to the other day on the train who experienced depression, was middle class, had good health insurance, was able to get. So fixing that has very powerful impacts both for her and for her child. That doesn't mean that we shouldn't do other things at the same time, that by changing the stressors she experiences in her community can reduce the overall likelihood later on. To me, those two strands go together.
Great. And one question that Megan, I'll ask you to start, and Olivia, you can feel free to add on, is that there have been many mentions of how folks can make a difference at the state level, but advocates are sending in some questions asking, what are sort of the first steps I can take to get the conversations happening in my states, or to get initiatives started in my state? So Megan, if you want to start, and Olivia, you can follow up.
Okay. Sure. So I think, first of all, this report that you all have done provides a great advocacy tool to do that. And so I think in addition to the report, collecting or pulling together, I apologize for the sirens in the background here, right next to a hospital, but any additional data that can be pulled together, local data, statewide data that might exist on maternal depression in addition to the report would be most useful.
So I think those are both great ideas, and I appreciate that's actually exactly how we hope the report will be used. I would add a couple things. I would say that now that you've heard Megan talk about her program, Donna talk about the policy, we became convinced during writing this that bringing together some of the people who really understand the local level service and the people who understand the policy levers is where you have to get to, because you need ideas for what ought to be fixed. So I think that working towards convening, meeting, developing a plan is very helpful. Some of the people we spoke to highlighted existing structures like early childhood coordinating committees that theoretically have Medicaid participation. Some states, I think we've talked to some people in New York State, New York City, are embarked on major mental health redesign. So there may be existing structures, but we would encourage you, I think it's on the next slide, is that where the resources are?
That's right.
Great. We would very much encourage that you reach out to us as you think about that, and we would very much encourage Philanthropy, as represented on the call, to think about what it will take to help states move ahead and do this learning. Because I do think we've concluded that this is a moment to get going right away, but that figuring out and implementing your plan is not an overnight matter.
Great. Thanks, Olivia and Megan. And I'll just mention, too, that at CLASP we're working on a technical assistance framework that goes along with the paper that we've been talking about on the presentation today that really will help be a catalyst for advocates and folks at the state level to work together to sort of begin having these conversations, and raises some important questions to ask at the table once all the appropriate people are sitting there. And with that, we are at the end of our time. And as I mentioned, if we weren't able to get to your question on the webinar today, know that we'll follow up with you individually via email in the coming days. And finally, just before we close out, I wanted to share these resources that Olivia referred to, and also let you know